Okay. My name is Warren George. I'm from Corvallis. My main career, I was Director of Primary Operations and Plant Manager for one of Oregon's largest employers, a titanium company. After that, I was a consultant. I was co-sponsor of the Elway poll of 2019, showing 62% of Oregonians would be willing to pay a considerable tax, 2 to 3 times the size of the state government, to fund universal care. And I served on the SB 770 task force. So I will do the fancy share screen maneuver here. And we will begin. Okay. I'd like to begin by thanking Oregon Physicians for National Health Program for inviting me to speak, and also acknowledge co-sponsors Healthcare for All Oregon, HCAO Action, Nurses for Single Payer, and Mid-Valley Healthcare Advocates. And of course, most of all, I would like to thank you for attending. Need for better understanding of the alternatives for achieving universal health care is especially acute right now as numerous states debate next steps. Oregon Task Force on Universal Health Care identified 3 major problems with our current healthcare system: unsustainable cost, unworkable complexity, including the financial anxiety, stress, and worry, the current system that cannot be measured in pure dollar cost, and inequitable access, including the way we divide people into groups which have different provider reimbursement rates. According to actuarial data from the Oregon Task Force on Universal Health Care, Medicaid now pays just 69 cents on the average cost of providing $1 of care. Medicare pays 81 cents. Private insurance has gradually risen to $1.37 to make up for the difference of declining Medicare and Medicaid reimbursements. Artificially restricting reimbursement for some patients has not reduced overall total cost, resulted in fewer and fewer providers willing to accept Medicaid and Medicare patients. Providers who see too many Medicaid and Medicare patients in their practice cannot cover their costs of staying open, so most providers limit the number of Medicare and Medicaid patients they will accept. Some refuse to see these patients at all. Another source of chronic inequity comes through the tie between healthcare and employment, since many disadvantaged groups have less access to the kind of jobs that offer medical benefits. Against those 3 major problems, we will evaluate 4 reform alternatives: mandatory purchase of private insurance, further expansion of Medicaid, a public option which would compete with private insurance, and a simplified payment structure, sometimes referred to as a single payer system. A flowchart of the financial system demonstrates how the current system works and how reform alternatives would affect the system. This flowchart may look complex, but it's actually simplified to only show some of the major components. The percentages shown here are based on national averages. The numbers will vary a little state to state based on factors such as how much Medicaid spending is used and the age of the population. In looking at flowcharts, it is important to consider all flows. Some healthcare alternative reform alternatives concentrate on 1 or just 2 specific boxes, but ignore the total. We will look at this flowchart in more detail after we start with a look at the history of how we got here. First, a little definition. We could label the box on the left patients, but since all residents are potential patients, it is labeled residents. On the other side, professional medical providers include any person, facility, or organization which provides diagnosis or treatment, including physicians, specialists, therapists, nurses, hospitals, clinics, technicians, and pharmacists. As little as a century ago, virtually all professional medical care was accomplished by a direct financial exchange between each patient and each provider. Adding one more level of complexity, charitable philanthropy has always played some role in healthcare. There are two types of philanthropy: donations of money and voluntary donation of time. 100 years ago, and for that matter, since the beginning of time, most care was provided at no cost by family members or close friends. The first hospitals, many of them started by religious volunteers, were founded to provide care to people who had no family to care for them. Family and volunteer care still exists at some level, but since this flowchart is a financial one, it will only show private cash donations used to pay for the care of others, or donations which are made to build facilities and provide major equipment for care. Here's an estimate that 100 years ago, about 98% of all healthcare was purchased directly from providers. About 2% was paid for by charitable private donations. Looking ahead at private donations over the years, private donations reached a peak in the 80s of about 5 to 6% as a percentage of total healthcare costs, and have since stayed in that same range. In any financial system, there is always some losses due to overhead. Up until the 1940s, medical system financial overhead was probably about 3%. Nothing else consisted of the doctor having to keep track of payments and going to the bank. In thinking of overhead, it is useful to think that for every dollar of actual care needed, residents will need to spend $1.03 in this case, since they also need to cover the cost of the overhead. As we shall see, overhead has been going up. By 1950, most professional care was still provided by a direct financial transaction between the patient and provider, but the use of middlemen was growing. State and county level programs, including some temporary assistance for people without income, was coming into play. Major medical insurance, similar to fire insurance on a home, was for rare but expensive events. With the rise of middlemen, overhead doubled from about 3% to about 6%. Through the 50s and 60s, reliance on middlemen increased dramatically as direct payments fell to less than one quarter of total cost. Employer-sponsored medical insurance continued taking a larger role in between the patient and medical providers. Employers got involved because of IRS rulings that allowed employees to receive health insurance benefits tax-free when arranged through an employer. Insurance gradually became regarded as a convenient way, if a more expensive way, to pay for even smaller medical bills rather than just for major care. Federal government, which had previously had almost no role prior to 1960, began assessing taxes to pay for Medicare and Medicaid programs, which grew quickly to cover about a third of all costs. Private donations had doubled to about 4%, and for providers, the proliferation of different insurance policies and public programs required major increase in billing staff. In this time period, total overhead had doubled again to about 12%. Jumping from 1980 to 2019, we see the continued decline of direct payments to close to 10%, and the continued rise of middlemen in the form of federal, state, local governments, and private insurance. In reading this flowchart, percentages on the right-hand side of the flow chart are how providers get paid, mostly by middlemen. For instance, 32% of provider revenue comes from private insurance plans. 22% comes from Medicare, about 17% comes from Medicaid. The percentages on the left side are how residents pay for healthcare, mostly through payments to middlemen. The largest current payments are through federal and state general fund taxes and through employer-based plans. Private donations still exist and is shown on the bottom row. Direct payments have fallen from the majority of all payments in 1950 to just 11.3% in 2019. About 4% is co-pays, deductibles, co-insurance, and the rest is to cover services which were not insured. For example, about half of dental and optical customers choose to pay cash, and most durable, non-durable supplies are purchased without insurance. Here is a 60-year trend line for direct payment, also known as out-of-payment costs. Note that although out-of-pocket costs may be rising in dollar terms, it continues to decline as the percentage of overall healthcare costs. Private insurance consists of both regular health insurers and medical portion of liability insurers, such as workman's comp, auto insurance, home insurance, and other liability insurance. Private insurance accounts for 32.2% of total payments to providers, with workers' compensation adding 1.3% and auto, home, and other liability adding about 1%. Medicaid CCOs, as exist in Oregon, are specialized private insurance companies covering close to 17% or higher. Looking at how residents currently pay for regular private insurance, employer-sponsored plans account for close to 30% of payments and are paid through workers foregoing wages in favor of medical benefits. Private individual policies shown count for 2.4%, include purchases of Medigap and marketplace policies subsidized by the federal government. Looking at government programs, Medicare and Medicaid are well known and account for most purchases of healthcare through government. Medicare accounts for about 22%, but note that Medicare payroll taxes and Part B premiums on the left side only cover about 11% of the cost, meaning that Medicare itself is only about 1/2 funded. The remaining half of Medicare and all of Medicaid and other programs are paid out of general fund dollars, which are the obligation of general taxpayers. For Oregonians, federal income tax dollars amount to about 27% of all payment. State income taxes add another about 9.9%, total of about 37% of all medical funding. There are many small federal and state programs and grants that are shown here, included in other programs. Should be mentioned that some Medicare payments are paid through private managed care organizations such as Medicare Advantage. National health expenditure accounts do not separate that out, so I did not show it here, but you should imagine some more ink, some more arrows going back and forth between Medicare and some additional private insurers. The flow just keeps getting messier. In the upper right corner is direct care, mostly funded through government programs. About 4.3% of all care is provided directly to specific eligible residents by the VA, Indian Health Service, public health programs, through other direct care provided by correctional facilities, schools, universities, and workplaces. Because this care efficiently serves very specific populations, these services are expected to stay operating as they do now, even under a universal care system. As you might have guessed, total system overhead has doubled again to about 25%, meaning that on average, we must pay $125 to receive $100 of medical care, $125,000 in order to receive $100,000 of medical care. This flow chart relies heavily on the Oregon Task Force actuarial models to depict the location of the 25% overhead efficiencies in Oregon. Expressed as a percentage of total healthcare costs, the greatest current overhead inefficiency is in provider billing. The next highest is in private health insurance overhead. Private insurance overhead can be quite high, as much as 20% on some individual policies. But since only about 1/3 of total medical financial flow passes through these private insurance companies, potential for total savings is less. Looking as a whole, the SB 770 task force found that the potential for savings is mostly in simplification and not in governmentalization per se, except as a route to simplification. Now getting back to a comparison of 4 reform alternatives against the problems of high cost, complexity, and inequitable access. Mandatory private insurance would require that anyone not on Medicare, Medicaid, or employer insurance must buy private insurance. This is the method attempted by the Patient Protection and Affordable Care Act of 2010. Forcing uninsured or underinsured individuals into mandatory private insurance may give a few people better access to care, but it raises overall cost. Some providers received a windfall from the ACA because more payment was received at the $1.37 rate, as in Oregon. Mandatory private insurance does nothing to address the major existing problems of cost, complexity, or other inequitable access. Many current state level programs, including in Oregon, where we're considering a basic health plan that starts next summer, based on expanding Medicaid to higher levels of income. Sometimes this is done to address the churn of people whose income varies, which could drive them in and out of Medicaid with associated disruption, medical providers who will see them. Further expansion of Medicaid has several effects. Presumably, income taxes will need to increase to meet the increased federal obligation. And because Medicaid only pays 69 cents on the dollar, any increase in the number of patients eligible for care at below provider cost likely to compound the problem of providers refusing to see Medicaid patients. Overhead could drop a little because Medicaid programs have lower overhead costs. Another problem with continuing to raise the percentage of people who are eligible for free or subsidized care is depicted in this simple graph of healthcare costs by income percentile. 1950, healthcare could be paid equally by almost everyone at standard prices. By 1970, 20% were eligible for subsidy, and currently about 1/3 qualify for some kind of subsidy. A plan proposed in Oregon would involve half of all residents paying little or nothing for their health care, shifting the cost onto fewer and fewer people. How far can we expect to go in this direction? This graph shows the dire importance of creating an economy where everyone participates through jobs which allow them to thrive. Oregon taxpayers in the 5th quintile are currently paying for over half of all healthcare, principally through their federal and state income taxes, which fund all of Medicaid and half of Medicare. Public options, where a public insurance company competes with private insurance, is a popular idea among legislators because you don't have to say no to anyone. But a public option actually adds to system complexity and cost by increasing the number of system components while eliminating none. A 2021 healthcare financing report by the Colorado School of Public Health estimated that adding a public option to a multi-payer system would add 2 to 3% to the total cost of healthcare. And any public option configured as a Medicaid buy-in has a problem that it will reduce the number of providers willing to see these patients at Medicaid reimbursement rates. Despite dozens of attempts in various forms, there are no examples of a successful public option. The reason they have failed are the potential savings of a public insurance company are overestimated. Public options have attracted very few customers. And the real killer, unequal distribution of high claims patients, which dooms premiums rates. The effect of unequal distribution of high claims patients is easily demonstrated. Most people need very little care, but a few need a lot. Which patients that private insurance company serves can be more important to them financially than what they charge. When private insurance companies compete with the public option, they only need to shift about 3% of their higher cost patients onto the public option in order to reduce their own premiums by 10%, dominate the market, driving the high cost public option out of business. Public options can't or wouldn't turn away high cost patients in the same way that private insurance companies can and do. Finally, we come to the alternative of a simplified payment structure, such as a single payer. In this structure, all existing private payment components for state residents would be replaced with one common payment structure. A simplified payment structure, such as a single payer system, is the only alternative that would actually address the major problems of cost, complexity, and inequity. Total cost would be reduced by 12 to 16% by reducing overhead. The distressing complexity of billing would largely be eliminated. Major causes of inequity would disappear because providers would be paid $1 on the dollar for care provided, regardless of who they see. And because obtaining health care would no longer be linked to employment, healthcare assessment could be significantly less expensive to residents than current premiums and out-of-pocket payments. Compared with the other alternatives, the simplified payment structure offers a path forward for future generations, which none of the other alternatives can come close to. If you would like a copy of my slides, you can email me at george@peak.org, and I'd be happy to share slides and engage in discussion. So thank you, and I will open it up for questions. I've stumped the panel.
I have a question. Where do you expect the most pushback from the corporate people and middle people who joined us in the 60s and 70s? We knew they were bottom feeders then, but nothing could seem to stop it.
Well, I mean, certainly insurance companies believe that they perform a valuable function, and a lot of their customers do. But what they're largely doing is gaming the system to try to keep themselves and their customers away from the high-cost patients. So on the task force, we did listening sessions, 16 listening sessions around the state. And there's a lot of attitude that says, you know, I'm healthy, and you know, a high deductible plan works well for me. That's my constitutional right. How are you going to take that away from me? So it's not just the insurance companies, it's actually a lot of regular people who really want to kind of game the system. This is not completely dissimilar to things that were going on in auto insurance in Oregon in the late 1960s into the 1970s, where auto insurance was going up at about 20% a year because some of the insurance companies had said, oh, this is really good. We're going to fight every claim. And, we'll send attorney and 2 accident investigators to every fender bender. And then the problem was that it was just driving the cost up. So states adopted no fault insurance that really helped to control the cost of auto insurance. And in my view, that's some of what's going on with healthcare is they think they're providing value added, but we'd all be better off if they just knock it off.
I have a question. This is Ken. Was the presentation you just did, is that your interpretation of the task force doings, or is that somehow separate and these are your opinions not related to the task force?
I have used some data from the task force, but the flow charts and things that I developed for the task force, but were not done by the task force.
Thank you.
Mike Huntington.
Yeah, Warren, could you put up that slide that shows the quintiles of supporting our healthcare system? My point will be, as you have heard from me before, that yes, the top quintile provides most of the funding for our healthcare system. The question is, if you were to put that graph into the amount of pain suffered by its quintile, it would look different. Could you comment on that?
Let me see if I can find the exact slide here. I'm actually not naturally left-handed, so
There it is.
I believe that you're referring to this one.
Yes, yes.
You could make that argument, and in fact, let me look at this a different way. If you just kind of remember what this looks like. And now I'm going to show you a very different graph, which is, and this is from 2013. This is the shape of people's income. So I was fairly amazed when I first looked this up, and very alarmed to see from about 1983 to 2013, the bottom 40% of all earners had been around 9%. And in a span of less than 30 years, actually has fallen to less than 5%. So this is one of the most, people don't talk about this much, but this really is the serious problem of our times of how do we deal with this type of economy. I mean, if you can imagine 40% of people trying to live on less than 5% of the income, that's a big problem. And so, yes, I'm interested in healthcare, but I'm also interested in improving economic activity. And one of the ways that I see to do that is to reduce the healthcare costs to employers. So that's one of the things that's driving jobs away. As Case and Deaton said, it's a wrecking ball that's destroying the lower middle class to have employers responsible for the cost of healthcare, because they're just making decisions to outsource, offshore, automate, or to turn regular employees into contract employees that don't get benefits. So it's all intertwined to me, and maybe that doesn't directly answer your questions about about pain. I'd hate to get to a point where everyone is in severe pain. I'd rather get to a point where we've kind of addressed the cost of healthcare to where more people can afford it. So, all right. Charlie.
So how do you foresee that we could get this sort of information to Oregon legislators? I'm thinking we have a lot of legislators who seem to be overly enamored with a public option, and also I would say even more that seem to think that having insurance companies like CCOs involved is a very useful thing. I'm wondering how do you think we could get more legislators paying better attention to some of these things?
It is difficult to get it in front of a few who really don't want to understand this. But and I see Bruce Thompson here. We called on Senator Patterson just yesterday, who's chair of the Senate Health Committee. And she was very pleased with this kind of thinking. And, there is some chance that we could get on the agenda for the Senate Healthcare Committee. Maybe it's a long shot, but she seemed to be interested in thinking in terms of that, just to kind of change some thinking. So it could be possible, but it's difficult, and thus far we haven't made much penetration putting this kind of information in front of the legislators. Does that answer your question, comment?
Yeah, it does, and I'm happy that Senator Patterson seems to be interested in this sort of thing and may be willing to have a hearing. So.
Yes, and I'll say just a few words about Senator Patterson. She mentions she spent some time in Canada, and she reveres Tommy Douglas, who, as a minister, put together the Canadian system. And something that may not be known to a lot of people is that Senator Patterson is a minister. And so she sees herself in that same kind of mold. And I think she'll be a real champion who understands the playing field very, very well. So, yeah, Lori.
Thank you so much for your hard work laying all this out in such a, laying the history and trends out so clearly. I have long been mystified why the political economic forces in this country that claim to be pro-business have insisted on tying healthcare coverage with employment, because it is, as you said, such a burden on businesses. And that's so nonsensical to me. If we're trying to both save money and to promote business health. I had a major accident 4.5 years ago, and I could just go into so many details about how money was wasted. And it had a lot to do with the low-level bureaucrats that we had to get through to make things happen. And it really reduced our healthcare. And the people that complain about Canada or England, and they have to wait 2 months for an appointment. I found this weird bump mole on my elbow that looked like I should get that checked for skin cancer, and that was early August, and I've had to wait 5 months, which means still have 6 more weeks to that appointment. 5 months to get an appointment for a dermatologist to check my body. So we are not doing better. And why the myth persists that we are, while 30-something% is being siphoned off for people to prevent healthcare from happening. it's very frustrating. So I really appreciate you having a, common sense argument in favor of simplifying.
And certainly my own experience is my primary care physician retired. And so I was left waiting for another one. And partly because of being close to Medicare age, virtually no one would take me. So for about 2.5 years, Immediate Care was my primary care physician. I currently have one, but because of insurance issues, I was maybe having to look at a different one. And this was back in June, and they said, "Okay, we can get you a first appointment with a physician. How do you feel about 2025?" And so, when people say, "Oh my God, they have to wait in England or Canada," I'm just saying, you have no idea how many people I met at Immediate Care who couldn't get a physician of their own right here in America. Thanks, Lori. Mary Lou?
Well, this is going to be a blatant plug. But some of you don't know, some of you do, that I've decided to run for House District 46 in Portland. And it's an empty seat at the moment. And I am going to be fighting hard to get myself elected and would love any support. Our web will be www.marylougetsresults. I've done a lot in the past, and I want to be one of those champions in the room. Deborah Patterson is supporting me, endorsing me, and so is Travis Nelson. We need more champions down there in the room, talking to them, getting to know them, helping them to see this. And so, while all of us are advocating from the outside, we need more on the inside. So I encourage other people to also run in places when a seat opens up, because I think that's part of it, is we've got to change who's there at the table. So anyway, you'll hear more from me. Thanks, Warren.
I appreciate your plug, Mary Lou. You've done so much for this effort over the years. It's great to see you finding new ways to contribute. Bill Harris.
I have lost track of the word from the interim committee on healthcare that we have had, I think now, for about upwards to 4 years, 3 anyway. Is there some word from that commission yet?
Could you make that a little clearer? I didn't quite get all of that.
We had a legislative interim committee on healthcare.
We've had
the process of having a new system for Oregon. If so, what and how? And I think the committee is still alive. I don't know of any information from it yet.
There are numbers of different task force. I served on the Senate Bill 770 task force on universal health care, which released its final report in late September of 2022, actually recommending a single payer type system. And as a result of the recommendation of that, a new universal care governance board with 9 members and executive director is being put together right now. The opening for application for executive director position closed about a week ago, and I'm told that there are some excellent candidates that they're currently taking applications for people to serve on the governance board to help create a universal care system. There is unfortunately a little bit of controversy of what that system could look like, and some of the legislators involved say, "Oh, let's go with a public option." So that's one of the reasons why I put together this presentation to show people that it's really not that good of an idea. There are some other task forces out there dealing with healthcare cost containment, and I know less about that. But if you have questions about that, I'm sure there's someone here who could address them. I hope that answers your question, Bill.
Yes, it does. Thank you very much.
Betsy.
Thanks, Warren. This is a great presentation, and I love thinking about it as encapsulating what we need to get our legislators on board for. I have a particular question that I've heard you mention a couple of times, which has to do with the administrative waste being largely in providers' offices and billing units rather than in the insurance companies. And most of us who are single payer advocates and have, studied this for a while, talk a lot about getting rid of this, the layer of administrative waste and profit that are the insurance companies in between the patient and the provider. And we know about medical loss ratios. Could you just explain a little more about why you don't think or know that most of the waste, so little of the waste, comes from our system of private insurance companies rather than what we know is all of the duplicative billing systems in every provider's office? I see those numbers. It's something like 4% versus 16%. If you could just talk a little bit more about that, it would be great.
I'd be happy to. And first, I should point out that these numbers are based on actually some models that were run under contract for Oregon Health Authority. And I cannot personally speak to the models. I'm just saying I'm using the data that they came up with and that were used in the final task force report, showing this result that most of the savings would come from the billing. And if you, there's a certain amount of narrative that goes either way. You think about the narrative that we often hear that Duke Hospital has more than one billing clerk per bed or things. So, there is some narratives that go against the billing. And of course, the billing is, it's kind of like this arms race with the insurance companies, one figuring out how to try to get paid and the other trying not to figure out how to not get paid. But comparing the 16% to the 4%, let me tell you how I got that. So I'm using numbers which the task force used from I think Bill Shao and some others, talking about how billing represents about 20% of billing cost is like 20% of the provider cost. So I'm noting that about 20% of the cost doesn't go through billing. It's in donations or some other things that really don't go through billing. So if I use that 20% number and I say 80% of that goes through billing, that reduces the 20% to 16% of total cost. Now, looking at the at the health or the private insurers, the national average for overhead costs, called the net cost of insurance, is something that the national health expenditure accounts track. And for private insurance, it's in the order of 12%. So, but one of the reasons that that might be lower, and that's 12% on the dollar that goes through those organizations. And so then if only the third of the amount of the total dollars goes through there, then the total savings would only be 4%. So that's how I got those numbers. I'm open to arguments that they could be lower or higher, but and there's certainly one of the reasons they aren't higher is that the overhead for self-insured employers is lower. So if you just concentrate on private insurance, you may be seeing, like I mentioned, numbers like 20% overhead. But if only, let's say, 2 to 4% of all insurance is going through private or personally purchased individual plans, then that's where, yeah, it's a big number, but it's only a smaller percentage of the total.
Warren, that particular interpretation of those numbers, though, is not entirely obvious. For example, if a doctor has to hire 2 additional clerks to be on the phone on hold with the insurance company because the insurance company wrote rules and is cutting back on service to doctors and doesn't care if people hold, the way you frame those numbers makes it sound like the insurance company isn't the problem is in the doctor's office. The problem originates in the way the insurance company drew up the rules that leads the doctors to do that. The perfect system is a concierge system, which only the rich can afford, and the overhead is 0. And that's not at all what we're interested in.
Yeah, I hope I didn't mince over that point. It's what I mentioned. It's an arm race. The providers have to do that to jump through the hoops in order to collect the money and make payroll. And certainly my view of a universal care system in Oregon is that, as far as Oregon residents go, at least, there would be hospitals without a single billing clerk. That the idea is that that's a function that no longer exists, that is covered by global budgets and other ways, and that if someone out of state comes in, for instance, in some cases it may be less expensive to just give them free care, like we get when we visit other countries, because billing them might be more expensive, or at least that the billing could be turned over to a single payer agency. Did anything I say help you, Betsy?
I think that was very helpful. Essentially, when we think about the 15% or 12% for private insurance companies, that's not for the entire system. However, it does make me think about the privatization and increasing insurance and private equity in our public systems. So if Medicare is increasingly having insurance companies which are taking a piece out of that public dollar, and I know more about that than Medicaid, it may be a little bit more than that 4%, especially over time as those trends continue. But that was a great explanation of that 4% versus 16. Thank you.
And to your point, Betsy, I'll display a picture here, which is my idea of private equity firms. It is a spider eating a honeybee, I think you get the point.
Yeah.
Lori.
Just to add to what happens in doctors' offices, not only do they have to hire people to be there and deal with the insurance company, but every insurance company defines the care in different ways. So it's incredibly complex for them. So even, gynecological exams, like some part of it it'll of course be given a different number, but maybe even a different name, and only part of it will be covered by some insurance and not by others. I mean, it's incredible. It's like our tax code. You have to hire professionals to deal with anything but the simplest stuff. And so that would be eliminated, presumably by having somebody, with a lot of common sense, figuring out what gets billed and what it's called and so forth.
And I have a friend who is CEO of Samaritan in Corvallis, and he says it would just be amazing what would happen if they could go on to a system like Global Budgets. The complete focus of their 5 hospitals would change from what do we got to do to make payroll to what do we got to do to keep people well. It could be just remarkable. And I think, it's not just people like us, but, here's an example of a chain of hospitals CEO who is seeing a lot of advantages to looking into this. Thanks, Lori. Mary Lou?
Just one quick thing. David Still, my husband, is on this. I see we're not at the same house tonight. So anyway, hi, David. But the other thing is his daughter is an occupational therapist, the feeding specialist in the neonatal intensive care unit here in Portland. And she says the incredible amount of just what you were talking about, that the different insurance companies, you code it this way, or how to get the most out. And so the trainings that go on and the wasted time that providers in all these places are having to sit through trainings on which codes and how to code it, and then having somebody that's a supervisor overlooking the coding and saying, no, this has to change. It's just kind of this never ending waste and bigger problem. And so, down at the individual provider levels, they're pulling their hair out. And a doctor that I know that worked at Broadway Clinic for his career retired early. And when I asked him, why did he leave? He said, Mary Lou, when I started, we had an overhead that was like less than 40%. When I left, it was almost 90. He said, I couldn't do it anymore. I just couldn't do it. So it's, people are leaving because of it, and it is, you're just right. And thanks so much for your exclamation. What is wrong with me tonight? But anyway, I've got whatever it is tonight. But anyway, this is what we have got to figure out, and to make it simplified, explain it, and have all of us singing that same song in a lot of different places, to get people to go, hey, we've been told a story that isn't true.
Yes. Thanks, Mary Lou. Bruce.
Thanks, Warren. Yeah, so I your flow charts, I had a couple of questions with. I think I raised one the other day with Senator Patterson in our meeting with Senator Patterson. But this is a little bit different. How does your flow diagram show the overhead of Medicare Advantage being administered by private insurance?
Well, it doesn't do nearly enough, and that's one of the things that I intend to add to it before I go much further, is to actually show the higher overhead cost and actually the bigger drain on taxpayer money. Both are happening because of Medicare Advantage. And it's, it sounds so wonderful, but it's hurting us kind of at both ends. They, and maybe not all, I don't know that all Medicare Advantage providers or insurers are equally bad. But certainly there's enough of them that really are pretty bad, both at figuring out ways to finagle money out of the how to get the Medicare trust fund to go dry a little sooner isn't something that I respect. And certainly there's a lot of risk because they're trying to charge less money by giving you less service and hoping you don't notice. Or if you are an expensive patient, they don't care if you go away.
Right.
They'd be happy to see you go to a competitor. So why would they give you particularly good service? And that's I'm maybe something that I haven't made enough point of is the only way you can make all these games go away is everybody in a single risk pool. Otherwise it's all gaming. I mean, it's people are trying to figure out way to arbitrage government money into different kinds of money, and it's just not good.
Yeah, and I just wanted to thank Charlie for reminding me to ask you that question. And
Well,
I want to support Mary Lou. I left medicine at the tender young age of 66 because of the moral injury I was suffering under from the insurance companies.
Yeah.
And your mention of Charlie, he's as good as they come when it comes to somebody to double check numbers with, and we're usually off by a couple of fractions of a percentage point, but we usually know why. So Mark.
Yeah, I just wanted to follow up on a couple of things that Mary Lou said. One is when you mentioned, Mary Lou, about and now Bruce has given this dramatic example for himself, but for the very first Senate hearing, Senate Healthcare Subcommittee hearing, 4 of us drove up together from Corvallis, and between us, we knew 3 doctors who quit because they simply couldn't take it anymore.
Yep.
We are driving doctors out of the field of medicine, and that's just overwhelming to me some days. The other thing, Mary Lou, several of us applauded when you said you were going to run, and we need more people to do that. Their applications are open for the governing board of the new healthcare system in Oregon. There's 34 people that were on this call at one point. I hope half will apply to be on that governing board. But in addition to immediately needing to make to become involved on a very political level, we have to bring along the next generation. Mike and I have talked about this several times, and encourage young people to begin to see themselves as leaders for our community. I've retired from Lynn Benton Community College, but I still teach the occasional class. And I have to say, the young people I'm seeing in these classes in the last few years are incredibly thoughtful and compassionate and bright human beings. The quality of writing has skyrocketed in the last few years. And we need to be mentoring these people, maybe taking the film of this talk or the Warren's slides and sitting down with somebody and going over it, but somebody who's 17 or 19. Anyway, that's the plug I'll put in. There's a lot of good young people, and they are scared, and they are concerned. They don't know what to do. It's, you know, the system's confusing, but we could provide a little guidance. Thank you.
Thank you. And it is a legitimate concern that there are doctors in Oregon who are getting, because they refuse to see Medicare or Medicaid patients, are getting paid at the $1.37 rate. And the question is, will they pick up and leave? And, you know, maybe some of them will, but one of the things that encourages me is the number of new physicians. I mean, you talk to the student chapters of PNHP, there are a lot of people who say, boy, imagine if I could practice medicine instead of go to billing school.
Thank you. Yeah.
And so, you know, I think we might lose fewer people like Bruce if we went back to practicing medicine. You know, I think the honest answer was we might lose some people, and we might gain some people who would come to Oregon just so they could be part of this system. So thanks, Mark. Joe, good to see you.
Yeah, Warren, thank you so much for your presentation. With regard to your comment about not being sure of which Medicare Advantage plans are decent or indecent, I'd like to suggest to you that you should pick up the telephone and call Wendell Potter. Wendell will fill you in very quickly, very thoroughly about which Medicare Advantage plans are abusers and which ones are not. And I don't think that there are, my own experience is that I don't think that there are any who are not abusing the whole Medicare Advantage. Thank you.
And Joe, while you're there, I would like to kind of ask your opinion about where doctors like to work from your own experience.
Well, I put in 50 years in both internal medicine and then also in occupational medicine. In my experience, doctors simply want to help people. Great majority of the doctors that I have been associated with in my lifetime. And my father, of course, was a world-renowned gastroenterologist at Mayo, and his example to me as a role model was something that I know many doctors have experienced from relatives who've been in the field. So yes, doctors simply want to take care of people. And
how does the VA attract doctors, for instance?
well, the same way. In my experience, the VA physicians are not only excellent, but they are dedicated. And there's simply no substitute for that. And when you do anything to defile that motivation in physicians and nurses, you're in deep trouble.
Okay, thanks, Joe. Ken.
Thank you, Warren.
So many of the physicians of a certain age on this call have observed their own experience. I count 4 generations of medical students and doctors in about 2 10-year increments who just leave the field because they say, this is not the field I started in. This is not the field I want to be in. I'm retiring early. And they're replaced by the next cohort of medical students who think that this inferior state of the healthcare system is normal and go through the cycle. And I think that will continue indefinitely. The dilemma that we have, I think the discussion about what makes doctors happy is a valid discussion, but it's a totally separate discussion. It may be that there's some legislators who are interested in it, but the issue of physician satisfaction is not central to what we're here to talk about. Having said that, I will say, those of you who are in some locations in Oregon are aware that nationally there is now a tremendous increase in the number of physicians who are working directly for corporations, whether they're intensivists or they're in practices that are associated with, say, Providence, which is where I get my care. They're employees. They're not small businesses. They don't run their own business. It will take some dramatic changes for that to change. I don't even know if we went to single payer tomorrow, whether that would change. I certainly hope it would. But one of the things that we are seeing is an increase in unionization of physicians. The first time I saw unionization of physicians was in New York in the 1980s, where one of the health plans directly employed doctors, and they had a union, and they had ongoing discussions with management, and every so often they had strikes, and it was a normal, reasonable process. I'm trying to remember where there was a doctors union just recently formed somewhere in the Pacific Northwest, and I think it was at Legacy.
It is.
And if I'm not mistaken, it was conceptualized shortly before they discovered that they're about to become OHSU employees, and what the heck does that mean for them? I think we'll see more of that. I think that's good. And I think it's a separate discussion from why we need single payer.
Hey, thanks, Ken. Alex.
Yeah, thanks, Warren. Love your presentation, no matter how many times I see it. So, a quick question. A lot of the efforts and thought is going towards influencing legislators, which is awesome. I'm involved in that a lot too. But I'm wondering, what's your thought on the executive branch? Because DCBS is appointing the executive director. They've closed the openings. They're appointing executive director. The governor is appointing a governance board. And then I think a lot, it seems like, there was a governor's signing letter on 1089 in the governance board. And, I'm not necessarily saying OHA or LPRO or any of those, but I mean, what's your thought on the executive branch and influencing them? Because I don't, it seems like that might be a target as well than just hitting on legislators. Just wanted your thoughts on that. Thanks.
Well, I think that's a wonderful idea, but I think that's a real uphill battle. There is, I was quoting just the other day, Upton Sinclair in 1906. It's difficult to explain something to someone if their livelihood depends on not understanding it. And if you look at Tina Kotek's background, she has based her career doing all of the things that we're saying are wrong. Getting these little bit of a snippet of federal government money here, and maybe just 20 more programs, and we'll have another 30,000 people covered. And I think it will be very difficult for her to see that in a different light. I hope we could, but I think that would be. I think for now, the executive branch will be hard to do without a lot of pressure from the legislature. That's just my thought. Anyone who, I don't know if anyone here who has a better take on our current governor, but I do think that her signing letter on SB 1089 completely tipped her hand. She spent half of the letter bragging about Medicaid expansions, which to me, that's a great thing as long as you believe there's an infinite amount of money out there, but I don't. And I believe that we all need to be more responsible with the money we have, and there's a way to do that. And it's not through some of these smaller programs that just keep driving the cost up higher, and also making it so doctors are less likely to see these patients who really need care. Does that answer your question, Alex? It wasn't good news.
No, that I was looking for your opinion, Warren. Thank you.
I want to reinforce what Warren said. I worked for the Oregon Health Authority for 25 years, and they don't do anything without legislation, and they do everything they can to keep their head down and not get it shot off. Oregon has a religion, a secular religion. It's called privatization. That nobody ever had. I mean, up until 1990, Medicaid programs were run by the states. They weren't privatized. Minnesota and Oregon were the first two to privatize in the late 70s. They actually weren't even particularly predatory by our current standards. But I was in New York City at the time, and when the private insurance companies wanted to get their hands on Medicaid, there was a big hue and cry, and they got put off for a good 10 years. But that's the secular religion of Oregon, and we haven't actually addressed that. And until that's addressed, it strikes me that it's going to be very hard to get our allies to actually do what we think they should be doing.
And Ken, that was especially painful to me on the serving on the Universal Health Care Task Force, is that we were getting support from OHA, and OHA was just kind of stuck in their own looking at the inside of their own glasses, and didn't really have the vision of what we were trying to achieve, and it really made it harder. I don't know if the new director of OHA will be change that organization any at all, but it's kind of has a certain sort of reputation, which is not to our advantage as far as creating change. Mary Lou?
One of the things when I've been looking through some old files and boxes of things, I came across, many of you maybe don't know, I was the first executive director and founder of Care Oregon. And we didn't have, 3 nickels to rub together at the time. And now as I read that they have $1.2 billion of our tax money in their assets, and it may go to a California company. There's just a lot of folks that are concerned out there, but I came across newsletters when we started writing the very first internal newsletter to our staff and the ones I found were October of 2000. And an interesting thing was the feature article in that little newsletter to our staff, and there were 70 people at the time, there are now 1,000 or more, it said that the Governor Kitzhaber on September 13th of 2000 held a summit in Eugene entitled The Oregon Health Plan, Consolidating Gains Moving Forward. But one of the interesting things right before that, the lead-in that the person who on my staff wrote this, quoted that Dr. Kitzhaber's attempt to create universal healthcare coverage for all Oregonians was the idea behind the Oregon Health Plan. It would be the first step in creating a healthcare coverage for everyone. And I think, John has fallen out of favor in some circles and has kind of, ceded into the background, but he still is, I believe, a player in the game behind the scenes a bit. And I just thought it was just interesting because even I, who was on his very first, there was a task force created to see whether it was ethical to have the line. Remember all the controversy about that we had a line that was drawn and the prioritized list. And I was on that very first task force that looked at the ethics of that with an ethicist out of California. And Kitzhaber, you know, came and talked about to our group about what his vision was. And, you know, and without kind of reading this article again, I kind of got lost in the fact that it was really concentrating on Medicaid. But I do believe he really did see it was a stepping stone to the overall coverage for everybody. And I still think that with so many people now on the Oregon Health Plan, that, you know, it is possible that we build on that and make, you know, everybody. So anyway, I just thought it was an interesting little piece of history that sometimes things have happened, you know, that even we who were there at the tables have kind of forgotten, and kind of resurrecting some things and holding some people accountable and saying, John, what happened here? You know, what can we do? So anyway, just a thought.
And to add to that thought, I mean, it really is a difficult thing for Oregon that we have not had a champion of healthcare since Governor Kitzhaber. There is no one who has stepped into that void, and he's still many times called in to be the speaker of what it's what Oregon's all about, and that was some years ago, and parts of that wagon, the wheels are wobbling pretty badly, and
some real problems with the CCOs in terms, I mean, here I helped start one, okay, but I could really see now. But part of the problem was you were talking earlier about influencing legislators, and, you know, Kotek just came from being a legislator not that long ago. Okay. But the CCOs have done a great job of lobbying and convincing legislators they're the best things since sliced bread. And Charlie has pointed out that other states have really done better on cost containment, a lot of things. So you don't have to have this model that we have. But now that we've got it, it's going to be difficult to figure out how to go forward with single payer and what role they might have or not have. I think it's definitely going to have to be dealt with.
Excellent. Thanks, Mary Lou. Charlie, your turn.
So my comment is actually quite a bit towards Mary Lou, and it's as one of the founders of Care Oregon, can you have some influence on they're not merging with SCAN? I know Warren has given some really good testimony related to that, but maybe some of your influence can help.
Well, I'm in a very difficult situation. I've started a scholarship that is trying to increase the number of BIPOC, for a better, I don't like the term, but people of color that want to be nurses, named after Billy Odegaard, who was the person who came up with the idea of Care Oregon, along with talking Peter Kohler from OHSU into it. And before all of this stuff about the potential SCAN Care Oregon thing, I approached Care Oregon and told them that they wouldn't have all their jobs and all the things that they had if Billy hadn't been the person who thought it up. So that I thought it would only be right that they name the scholarship the Billy Odegaard Care Oregon Scholarship and endow it with $3.5 million. Now, I haven't got all of that money yet, and I am still trying to get it, but it all got caught up then in this merger thing or this acquisition. And so I've actually, if I don't know, there's a spy on this call or not, but anyway, Eric, the CEO, has called and wants me to talk with him next week. And I thought it was about getting the rest of the money that I want. And I was told by his assistant, no, it really was to talk about the new potential thing going on. And anyway, so I'm in an awkward spot because I've tried not to speak out and stab him in the eye. But I've been encouraging other people to to write and to comment, etc. And kind of depending, I will be very sad if I can't get that funding from him, because then I have to get it from all kinds of other places, and I'm constantly after people for money. And now with a campaign, we go again. So it's, people are like, Mary Lou, what is it this time? And so I was just really hoping to get this endowment. And anyway, now it's all out in the open that it's a bit problematic, but go for it, you guys, please speak up.
Okay, well, we're coming up close to the end here. I'll remind people again, if you would like to see copies of the flow charts or things, you can email me at george@peak.org. And, occasionally we learn some new things or add some new things. And like I say, these are pretty much based on national numbers. And part of my reason of doing that is this presentation has been given in multiple states. But I hope to end up before long with a very specific Oregon version of it. So anyway, I'm really pleased to see many friends here, including from people from Southern Oregon down there, and lots of others here. So this was a Oregon PNHP meeting, but actually no business was conducted, but a meeting next month on the 26th, I think, of December to conduct some regular business.
Right. Thanks again, Warren. It was a wonderful presentation.
Thanks so much.
Thank you.
Thank you again.
Take care.
Thank you.
Thank you. So, Mike, I guess you can stop recording.
Okay.